This is always a very nice but bittersweet day for us at UCSF and the Department of Medicine. I'm Bob Wachter, by the way, chair of the Department of Medicine. This is the Reza Gandjei Memorial Lecture, and it's actually our 26th annual. Hard to believe, as so many years have gone by. My memory of Reza is very fresh. So let me tell you a little bit about Reza Gandjei, for whom the lecture is named, and then I will tell you about our speaker. So Reza was a native of Iran, did his secondary school in England, and then went to Berkeley, as did which is where our speaker is on the faculty now, where he demonstrated his precociousness early on, developing an early course on bioethics for Berkeley in medical issues. He then went to Harvard Medical School and was a standout student and an innovator, outside the box thinker there. And we were thrilled to recruit him here to UCSF, but only after he had gotten both a Rhodes and Marshall scholarship, which is extraordinary. And had spent time in England getting, actually, I think, 2 different master's degrees. Came to UCSF, where he was an absolutely outstanding resident, both as a clinician and a teacher, but also really one of the most remarkable thinkers I've ever met, someone who really thought outside the box, questioned dogma and orthodoxy, and was thinking about the important issues in health and health policy and ethics all the time. And sadly, Reza passed away at a young age, and we have been privileged to keep his memory alive, in part by having this lectureship every year and having many of Reza's family and friends attend, and they are here with us in the audience. Reza would have been excited, but also skeptical of the topic of today, because that's the way Reza was. He was excited and also questioned sort of the prevailing truth, and raised really powerful issues and things like, we talk about bias and some of the challenges with the digital transformation of medicine. He would have been the first one to raise them and would have always brought up interesting points that none of us would have thought of. So I miss him a lot, and I know really very pleased that his family and many of his friends are here with us. Since we started the Reza Gandjei lectureship, we have had some of the great leaders in American medicine who tend to think about issues around policy and ethics join us, including people like Chris Castle and Bernie Lowe, who's here in the audience, Mary Naylor, Andy Beinman, Michelle Mello, Atul Gawande. Others have graced us with their presence and their talks. And we're thrilled today to have another absolute leader, international leader in medicine, speak to us. Now, the topic is AI, and those of you who've been following know I gave a talk on AI 2 weeks ago. Mine was sort of the view of AI from someone who really doesn't understand how the thing works, and from the perspective of a clinician and someone who's leading a department. Today's, I think, is different from someone who really is a world expert in not only how it works, but some of the implications of AI for healthcare. So I think it'll be a very different angle. While I think of it, by the way, next week's Grand Rounds is canceled. There's a School of Medicine and Health System session looking at provider burnout and the Net Promoter Scores. I think it'll be an important session. So we will cancel ours. I'm going to be doing my State of the Department talk here sometime, I believe, in March. So we will let you know about that. Today's speaker is Ziad Obermeyer, who's Associate Professor and the Blue Cross of California Distinguished Professor at the UC Berkeley School of Public Health. Ziad is an ER doctor by training and still sees patients in an emergency room in rural Arizona. I think he goes out periodically to keep his skills up as a clinician and really understand what clinicians face in the new and very rapidly changing world. He spends his professional time building machine learning and AI algorithms and studying them for both expected and unanticipated consequences. His work has really helped educate all of us on some of the challenges and some of the hazards of these systems, things that we have to watch out for. And his work has been highly influential in policy and in regulatory circles as people are trying to figure out how do you put limits on some of these tools so they don't cause harm. He's a Chan Zuckerberg BioHub investigator. He's a faculty research fellow at the National Bureau of Economic Research, and he was named one of the 100 most influential people in AI by Time Magazine, and an emerging leader by the National Academy of Medicine. He's been published in all of the major journals, including Science and the New England Journal. He's also co-founder of something called Nightingale Open Science, a nonprofit that takes advantage of AI to try to make healthcare better for research, and another tool, Dandelion, which is a platform for AI innovation in health. Before we were able to woo him to Berkeley, he was an assistant professor at Harvard and a consultant at McKinsey. So Ziad's talk today is, what does AI mean for medicine? I'm looking forward to it, and thank you so much for coming and joining us.
Thank you, Bob, and thank you so much for having me here. It's very inspiring to hear about Reza and to be part of this event. So thank you to the family as well. I thought of what would be interesting to talk to a group of people who know a lot more about medicine than an emergency doctor. So I'm going to try to avoid making a fool out of myself by talking about nephrotic syndrome or other things that I don't really understand, and stick to things that I do understand a little bit more. And specifically, I'm going to talk about two areas where I think AI is going to change a lot about medicine. And the first of those things is AI is very good at solving a particular kind of statistical problem that I'll call a prediction problem. It's exactly what it sounds like. It's predicting something that's going to happen. And I'll show you one example of this, but I think once you see the template, you'll see it everywhere in medicine. There are so many of these problems, and they are so important both for patients and for the financial solvency of the healthcare system, that I think AI is going to be extremely influential in reshaping how doctors and others in the healthcare system make decisions. I think there's another dimension that I'll also try to touch on today, which is that AI is also going to change how we discover and build new knowledge in medicine. And the core insight there is that, we as humans have a certain set of perceptual, apparatus and cognitive, there's some hardware and software that we have that's genuinely very impressive. I think that people haven't figured out how to reverse engineer yet. AI is different. It's like an alien intelligence that is built differently, that inputs and outputs different things. And that can be incredibly valuable as we try to rebuild or if you're a skeptic like Reza and like myself, build a science that underpins that medical practice that we engage in every day. So the example that I'll try to use to illustrate those two things is what I've been working on. It's actually the project that I'm most excited about, which is discovering a new biomarker for sudden cardiac death by applying deep learning to the ECG, and specifically to the ECG waveform without human interpretation of that waveform. So let me start with the decision-making part. I have only seen this once, but if you just do the math on, what's the prevalence of this problem and how many patients you see, guessing you probably should see this every few years. And specifically this, in a patient who comes in with some lightheadedness or syncope. And I saw this once in the emergency department at the Brigham. And the next step was actually pretty clear, both to me, because I dutifully memorized what you do with this problem, and to the cardiologist that we consulted, which is placing a defibrillator. And the reason is because in people with that dolphin-like ST elevation in the anterior leads, those people go on to have a very high incidence of the arrhythmias that a defibrillator prevents. So ventricular tachycardia, ventricular fibrillation. And I want to point out that this is a great example of a prediction problem, which is to say that when this syndrome was first discovered, we didn't have any idea what the molecular mechanisms of that syndrome were. And we certainly, and still don't have any randomized trials showing that a defibrillator is a good idea. But it stands to reason that in someone who is going to go on to have a high incidence of arrhythmias that kill people, those people are going to benefit from a device that terminates those arrhythmias and prevents those people from dying. And I think it's an example of both the importance of prediction problems. In other words, if I knew that someone was going to go on and have one of these arrhythmias, I would definitely want to put in a defibrillator. And also the importance of, and the validity of clinical reasoning, even without big randomized trials telling us that it's a good idea. It's like parachutes on some level when you get into this level of specificity. Unfortunately, Brugada syndrome, which is what this problem came to be known as, only represents a small fraction of all sudden cardiac deaths. That paradigm of predicting risk so that you can prevent it, though, seems very general and not just limited to this particular genetic syndrome. So how are we doing when we try to apply that paradigm more broadly in our effort to prevent sudden cardiac deaths? Well, here's my view of the current status. In the US alone, and the estimates vary, there are hundreds of thousands of sudden cardiac deaths, which means that there's a lot of false negatives to our current approach. There are a lot of people who are dying who don't have one of those defibrillators placed. And as Ziad and I talked about this morning, sometimes even when they do have a defibrillator placed, that is not enough. On the other hand, there's a sizable fraction of defibrillators that never fire. So we've gone to the trouble of implanting this thing into someone's heart with all of the costs and the risks of that procedure, and it doesn't do any good because that person, we thought they were at high risk, but it turns out they weren't. And so there are a lot of those false positives as well. So we're making both of these mistakes. And I think given the magnitude of this problem and the fact that it should be, in theory, a preventable problem, I think this is it's a daily crisis in medicine that I think we've lost some of the shock of because it's just part of our everyday knowledge base that these things happen. So the central, I think, scientific challenge here is what's been called the low risk, high number problem, which I like because it tells you exactly what the problem is. Most deaths, most sudden cardiac deaths occur in a very large population who are at low absolute risk of sudden cardiac death. And that means that when you think about, okay, well, I want to place the ICD if the benefits are greater than the costs, those people don't have a risk that's high enough to justify the costs. So the likelihood that they're going to have one of these arrhythmias is just too low to justify both the financial and the health costs of messing around with someone's heart. While only a small population of people, like people with Brugada syndrome and other definable illnesses, have a high enough risk that the benefit is greater than the cost. So that's the big challenge in trying to solve this problem at the population level. But that's all a reflection, not of some, truth, but it's just our current prediction technology. So all of this is a statement about known risk factors for sudden cardiac death that creates this low risk, high number problem. So what's the current prediction technology? Well, the cornerstone of predicting risk right now is ejection fraction. So you get a cardiac ultrasound, a cardiologist, or increasingly an artificial intelligence algorithm looks at that video and tries to quantify the amount of squeeze of that heart. And you'll read the statistic a lot, which irritates me, that 50% of all sudden cardiac deaths have a low ejection fraction, which is our high risk marker. But that's only of the 10 to 20% of people who have that test. So in fact, only a very small proportion of people have a known low ejection fraction ante-mortem. In addition, people with low ejection fraction have a lot of other things going on that can kill them that are not these arrhythmias that the defibrillator prevents. And so those people might have a lower benefit even than others because of those competing risks. There's a bunch of other tests that basically have the same problem as cardiac ultrasound, which is that they're expensive and hard to get. So you can get a cardiac MRI, there's PET and SPECT, there's genetic testing, there's electrophysiological testing. But all of these things are going to give you that small number problem. So even if you identify someone at high risk, you cannot do cardiac MRIs on everyone in the population, especially when we know that risk is dynamic and you might want to do that every year if you were genuinely concerned about the risk. So ECGs are kind of interesting. ECGs, there's been a lot of work trying to figure out if we can predict risk accurately based on ECGs. And so far, basically nothing is ready for prime time. And a big problem with the ECG for this purpose is that getting a human to identify the thing on the ECG is a huge bottleneck in this work. So it's costly to get a cardiologist to do anything, but especially to sit in a dark room and label these hundreds of thousands of these things. And it's also noisy because two cardiologists don't always agree on whether that thing is there and how long the interval is and things like that. These constructs that we have in our head, like the P wave or the QRS complex or the T wave, are not, these are abstract concepts. And when it comes to measuring them, their height, their asymmetry, their, whatever, reasonable people can disagree. So, whenever you say, oh, like humans are bad at this, the next step is like, well, AI is going to be great at this. But there's a problem here, which is that what do we predict? If we train the AI to just predict what the cardiologist is going to say, we're going to end up with all the same problems that the cardiologist has to begin with. So we probably don't want to do that. But what do we do? So here's what we do. So I was very lucky 8 or 9 years ago to be connected to a cardiologist in Sweden. And this cardiologist was putting together a data set that collected all the electronic health record data in that region of Sweden. And because it's Sweden, once you've got like the equivalent of the social security number, you can link everything to everything, including death certificates. Now that was 8 years ago. And one problem with doing work in Sweden is that there are a lot of papers that need to get signed for a PhD student at Berkeley, for example, to get access to data in Sweden and have a GPU that you can run machine learning models on. So one, I think, not great note about how this happened is that this was very lucky, because also around 8 years ago, I met the person who is now my wife, who is from the same region in Sweden as that cardiologist. And it was a total coincidence. And so that meant that every summer we'd go and visit Sweden, and I'd have coffee with Marcus, and I'd be like, hey, how are all those signatures? How's the IRB approved? How's the linkage? How's the approval for the death certificates? Did you buy those GPUs? Like every summer. And that's how this project came to be, which is, sadly not a great model for doing this work. As they say in the Bay Area, it won't scale because I can only get access to Swedish data now. So anyway, but given that I have access to this data now, here's what we do. So we just get all of the ECGs that were ever done in this region of Sweden. And so that's like hundreds of thousands of ECGs over this time period from about 120,000 patients. And we get the waveforms themselves from the XML files. And we link those ECGs not just to the full electronic health record data, but to death certificates. And because it's Sweden, the coverage of these things is just both the electronic health record data in a nationalized health system and the death certificate linkage is much better than we could do anywhere in the US. So this is a huge asset. And then we just look at the sample. And so we're going to be talking purely about what, in medicine we call younger people, so under 80 years old, and people who have gotten an ECG. And so the mean age of this population is 59. Most of these ECGs are from clinics, outpatient settings. And of that population, only 12% have an echocardiogram. So already we know that we cannot be doing very well for risk prediction for this population if only 12% have the leading test that we use to risk stratify people. So cardiac death is rare, and we use, for all of its flaws that we'll come back to later, the standard epidemiological definition, which is a set of ICD codes that indicate either a cardiac death or an ill-defined cause of death, and a death that happened outside of the hospital or in the first 24 hours of a hospital stay. We'll come back to why that's not a great gold standard and why we need to supplement this with other information. But ejection fraction, as you can already know from the 12% figure, actually here, 80% of those sudden cardiac deaths or presumed sudden cardiac deaths have a low left ventricular ejection fraction, but only 25% of those deaths had an ejection fraction measured. And so the majority of these people would not have been considered high risk antemortem. And in fact, when you look at those deaths and you just say, okay, well, apart from hypertension and cholesterol, like who looks sick, 2/3 of these people basically are healthy, walking, like just hypertension or cholesterol at most. So these are not people who look sick on any other margin. Okay, so there are just some small details about the machine learning that I'll go through quickly, but happy to talk about more. So we've got the entire sample of all the ECGs. And the first thing we do is we take 40% of patients and we put it in a data lockbox that nobody has ever touched. and we still haven't touched. And that's a very important machine learning principle, is you need a totally independent sample that nobody touches until everything's done and you're ready to publish. We train an algorithm on 30% of patients with one little asterisk that I'll come back to in a second. And all the results I'll show you are from this other 30% of the sample that the model has never seen, plus all the patients who have a defibrillator implanted. And I'll come back to that in a second. The modeling approach, it's pretty standard. We've got a waveform. We train a neural network. We predict whether someone's going to have a presumed sudden cardiac death in the year after that ECG. We add a predictor of, if they die, is it a cardiac death? And we ensemble those two predictions together to form our final prediction on whether this person is at high risk of sudden cardiac death over the next year. We chose the architecture by basically just looking at the kinds of models that work for ECGs in the literature and verifying that we reach the same performance on a lot of things that we see in the literature. So this is a basically good general purpose model that we're adapting to this purpose. All right, so how does the model do in this holdout, the validation set of data? Well, the AUC is 0.845. And normally in a machine learning paper in medicine, that's the end of the paper. It's like, great, the AUC is above 0.8. This is good performance. But obviously this is not the end of the story. And the AUC is a fairly unhelpful metric when you're trying to figure out, is this thing actually useful clinically? So here's one way to think about this question, is like, are we identifying a clinically high risk population where we would actually consider putting in a defibrillator? So how do we know it's clinically high risk? There aren't formal guidelines of like, if your risk is above this, then you get a defibrillator. But there are a lot of clinical trials of defibrillator where they randomize people to getting a defibrillator or not. So what we do is we actually just look through all of the trials that report the sudden cardiac death rate in the control group. And we say, well, these people are we're ethically comfortable randomizing these people to getting an ICD. And so we're going to take the median of the sudden cardiac death rate over 1 year from these clinical trials, and that's 4%. And we're going to say that's our threshold for clinically high risk. Sorry, I'm used to presenting to like economists who are like very active in this. Please interrupt me if you have any questions. Does anyone have any thoughts or questions so far on anything? Okay, please don't hesitate to interrupt. So 4.4% of the ECGs in our sample have a risk that's above that threshold. So this model is identifying a pretty large clinically high risk group. And those people make up 25% of the SCDs, the people who go on to have SCDs, who are in that high, so that we're already actually doing quite a bit better than ejection fraction in terms of identifying a population that makes up a large population of sudden cardiac deaths. And if we look at the top 1% of ECGs, they have a 6% per year rate of presumed sudden cardiac death. This graph is showing you on the x-axis, this is what our model thinks. So we ranked people in the sample from low risk over here at 0 to the highest risk people at 0. And we did that both for our model, which is in the orange, and for a model that's based on left ventricular ejection fraction. So what we do is, for the people who have ejection fraction, we use ejection fraction to predict risk, and we train it the same way that we train our model. And for people we don't, we just use age and sex, which is the only other thing that we use in our model. So basically we're comparing two models. One of them uses age, sex, and our ECG model prediction. That's the orange line. The other uses age, sex, and LV ejection fraction. That's the blue line. And you can see that both of these models are kind of overlapping. So, you know, the rate of sudden cardiac death is going up slowly, slowly, slowly. And then for ejection fraction, it kind of stops here. And here, even the highest risk people have below a 3% rate of presumed sudden cardiac death at 1 year, whereas the top 1% of our model get up to 6%. Some other interesting facts is that this model is predicting well, both in the subset of people with a known low ejection fraction and the subset of people with a high known ejection fraction. And even though we did not train the model to predict ventricular fibrillation or tachycardia, our model predicting presumed sudden cardiac death actually does a pretty good job of predicting incidence of VF and VT over that next year too. So there's some overlap in the risk that we're predicting and this mechanistic insight about the cause of these potential sudden cardiac deaths. So I think if you look at the literature over the past 10 to 20 years, even before the AI bubble in the literature, there's like a lot of people predicting sudden cardiac death. This is a bit of a cottage industry. And, I think my reading of that literature is that there are a lot of things that can predict sudden cardiac death or presume sudden cardiac death in different settings. But we're not just interested in predicting, we're interested in preventing. And so how do we get some reassurance that what our model is picking up on is actually not just predictable, but preventable? So I'm going to come back to that group that I took out of the set that the algorithm learned from, the people with defibrillators. Now we're going to put those people back into the validation set. And we're going to look at those people. And it turns out we're very bad at predicting what's going to happen in those people. So in those people, we dramatically over-predict the rate at which they're going to die. So our model, which has not learned anything about defibrillators, because the sample it learned from had no patients with defibrillators, is like, this person looks like they're going to die. But when we look at the actual outcome, those people end up dying 7.5% less when they've got an ICD in place than when they don't. And I can talk through the coefficients, but the left ventricular ejection fraction high risk people, actually, that doesn't add anything to knowing who's going to have a better outcome when you have an ICD. So our model is picking up both on the known benefit of ICDs in the people with low ejection fraction, but also a bunch of other people that are not being picked up by the low left ventricular ejection fraction. And so I think that suggests at least there's some circumstantial evidence to believe that this model is also identifying a group of very high risk people who die less when they have a defibrillator placed. And that's interesting. Okay, so the last thing to know about this predictor is whether or not this is a good predictor in Sweden, but nowhere else. In Sweden, it's a wonderful place, but it's a weird place, and it doesn't look a lot like the rest of the world, or whether these things generalize. And all I've shown you so far is that this works in other Swedish people. And one of the major drivers, of course, of algorithms misbehaving in the world is failing to generalize from the population it was trained on to the population where it's ultimately applied. That can look very, very different from the population it was trained on. So we're going to get data from a totally different source, which is a cardiac arrest registry in one of the largest hospitals in Taiwan. This is the University Hospital in Taipei. And what they do is whenever someone comes into their emergency department, either with a history of arrest in the field or who arrests in the ED, they enter that person into a registry. And then a team of doctors and nurses follows that patient in the ED and then in the ultimate hospital course, and they try to get to the bottom of what happened. They interview family members, they talk to the paramedics, they do all this stuff, and they adjudicate the presumed cause of this arrest. And so what we do is we get those arrests, and then we sample a set of controls, people who visit that emergency department on the same day. And then for both of those sets, we get their last ECG. So not the ECG from the arrest or the control visit, but the previous ECG from the electronic medical record. And then we apply our model to produce predictions on those prior ECGs, median about a year before that visit to the ED. And what we find is that that predictor actually does a pretty good job of discriminating between the cases, and specifically the cardiac arrest cases, as opposed to the pulmonary etiology or other etiologies, versus the controls. And one interesting footnote here is that that's based on age, sex, and ECG waveform alone. If we add in other variables from Sweden, it makes the model better in Sweden, but it actually makes the model worse in Taiwan. So there's something about that waveform that is even more than the structured data in the electronic medical record, predicting these deaths. And I think that also helps, at least it helped me feel better about the fact that we were capturing something about the physiology of the heart, not some idiosyncratic thing about how ICD codes are billed or recorded in Sweden versus Taiwan. It also means that given that the ECG machine knows the age and the sex, because the tech has to put that in to do the ECG, this could actually be its own standalone diagnostic product. You don't need to integrate this into Epic. which is nice. If any of you have tried to integrate anything into Epic, this could live on its own, just on the basis of the ECG data, without having to pull data from the rest of the electronic medical record, which is a big asset. Okay, so would love actually feedback on next steps from this very smart group of people, but here are some things we're thinking. So in this sample, there are about 200 people who have had a cardiac MRI, and we're getting a cardiologist to look at those MRIs blinded to the outcome and to the risk prediction to try to figure out, like, well, what do these hearts look like when we predict high risk versus low risk? Like, what features stand out to that cardiologist? We're going to, once we finalize all of this stuff, we're going to submit the current version of results to a journal. But then when it eventually finds a home, we're going to, we're going to get accepted. And then we're going to retrain the model on the 60% of the data. We're going to produce the results on the 40% of the data. And whatever happens, happens. So we're not going to peak, and we're just going to publish that final result. And that's kind of I think, good machine learning practice. And then I think maybe the most exciting part is that the region in Sweden where we're getting the data is very interested in following up on this. So getting primary care doctors, for example, to investigate more some of these high-risk patients, whether it's getting them an echo, doing a very careful history to try to figure out other potential causes of arrest and rule those out, or doing whatever investigations that person wants to do. And I think that's a very exciting way to get more information on these people that might be high risk with a view to getting them the right therapy. All right, let me pause there and just see if there are any questions or comments on that part so far.
Yeah. Question, you raised that Sweden has a very specific population. Taiwan has a very specific population. How do you get access to like a really diverse population to test this on, rather than knowing that this works in two very specific subsets?
Yeah, thanks for asking. This is something I spend a lot of time working on, just because it's so important to my research. But I think it's also important to anyone who's interested in knowing if the algorithms that people are building work, in populations that they care about. So one of the other things I'm involved in is I helped set up a company. And the company partners with a set of non-academic, large integrated delivery networks in lots of different parts of the country. So Southern California, Northern Texas, the Dakotas. And between those health systems, there's a very, very diverse population on lots of different dimensions. And the business model of this company is basically to help people who want to build clinical products for patient benefit to get access to data that they need to build those products. And we can talk, I think there's a lot to talk about in terms of the ethics of that I've thought about a lot, but I'm going to just answer your question and say that because I'm one of the co-founders of that company, I have some say in what that company does. And one of the things we're doing is we're setting up academic partnerships where researchers at, for example, Berkeley, but also MIT and other institutions can access that data to publish research and to do exactly these kinds of exercises. We've also, with philanthropic support from the Gordon and Betty Moore Foundation and from the SCAN Foundation, the company, and again, this is a free public service provided by this company because, I get a say in what the company does. Anyone who has an algorithm that works on ECGs can actually upload their algorithm in a container where we don't get to see inside. We will run that algorithm for free on the data and generate a performance report that tells them how the algorithm is doing overall, but also how it's doing in racial, ethnic, geographic, socioeconomic groups, but also different care settings. So it turns out that a lot of ECG machines in community health centers and outlying hospitals have a different sampling rate than those done in tertiary care centers. And that breaks a lot of algorithms that are trained in academic medical centers. And that was not known before we started doing this work. So it's getting more people access to data in a safe and ethical way is something I care very deeply about. And I think it helps me and other people do research, but it also helps answer these really important questions about how algorithms are working and how equitably they're working.
Are you able to then ask the AI, what patterns are you seeing? So that it can actually teach you, oh, well, actually, we're noticing that when the PR morphology looks like this and the C looks like this, and maybe you've never thought of that, but here, is that?
Yeah, that's part two.
Oh,
Yeah.
sorry.
Perfect timing. All right, yeah, I think that's a fascinating question. Let me, before we get there, tell you a related story. And this is a story about medical discovery, and we're going to go back to this. So this story starts in the early 1980s, and there's a Spanish cardiologist who ended up working in the Netherlands. And he's working one day, and this 3-year-old child comes in cardiac arrest. And miraculously, because like, as you'll see from the story, there are a lot of weird coincidences, just very improbable events. So 3-year-old has a cardiac arrest. The father was basically like a soldier of fortune who was a mercenary in sub-Saharan Africa. And because of that background, he was trained in CPR. So he did CPR on his 3-year-old son, and the 3-year-old son survived to get into this hospital in the Netherlands, where the 3-year-old had an ECG. And the ECG looked, it's hard to find the original, but the ECG probably looked something like this. And the 3-year-old survived. And then it turned out that 3-year-old had an older sister who'd had a cardiac arrest and died. And she died at a hospital in Poland, but miraculously they'd done an ECG on this young child before she died, and her ECG looked just like this. And so that was very noticeable. And basically, this was the beginning of the discovery of this syndrome that we now know as Brugada syndrome. But there are already all of these just very unlikely things that have happened. And then they keep happening. And so basically, they wrote around to their friends and they asked if anyone else had seen this pattern, and people started sending ECGs. And some of them had this pattern, some of them didn't. So now they've got 4 ECGs of people who had cardiac arrest, otherwise unexplained, that had this pattern on the ECG. And then they tried to get it published in a journal. And this did not go well because, I think, why didn't it go well? I think everyone has a bit of an immune system, like a mental immune system against new things. And the reviewers certainly did. The reviewers were like, this is just a variant of something we already know about. And it was actually only when the cardiologist was at a conference and ended up sitting at dinner next to the editor of a cardiology specialty journal and was like, I've got this interesting paper that everyone's rejected. And the editor's like, yeah, we'll probably take it. And it's now one of the most cited papers ever because that was the discovery of Brugada syndrome. So if you think about, so that's the story. Let's just try to distill that story into the objects that are going on here. So there's one object is cardiac arrest in a young child, and that is very noticeable and very salient. So you have to think, what if that person had been 93 years old instead of 3 years old? Would we have noticed this enough to go get ECGs from family members? Probably not. What if he'd been an only child and didn't have a sister? We pay a lot of attention to some kinds of deaths and not others. And in particular, I think we don't pay a lot of attention to older people who die, even when they're in perfect health. And this actually, I don't know if you know the story of the most prolific serial killer of all time, but he was a doctor, and he took advantage of that fact that we just don't notice when older people die, even when they shouldn't die. All right, so that's one interesting fact about this. The second interesting object is the abnormal ECG. So this is the dolphin-shaped pattern in V2 and V3 has a very noticeable and distinctive thing that just looks different. But you have to wonder, what are the things that we're missing? So if there are subtle relationships, geometric relationships, something that should be there if we see this here but isn't there, we're going to notice those things as humans? Probably not. But, the next object in the story is a correlation. Now, notice that you have to kind of think about this being a correlation, but basically this event, cardiac arrest in a young person, is very rare. This ECG pattern is very rare. what are the odds that these two things are unrelated, like extremely low? So we assume a correlation because of the conjunction of these two rare events. And at first, that's all there is, just a correlation between arrest and weird dolphin fin shape. Then what happens is that there's a hypothesis. So there's a hypothesis that there's some underlying state that ties these two things together. And sure enough, after a couple decades of work, the genetic and sodium channel pathology underlying this thing was elucidated. And we now understand this object of Brugada syndrome reasonably well. So that's, I think, a great story about like a template for medical discovery. Now let me kind of try to make the link between that and what we've done. So our model also sees a correlation. So it's correlating sudden cardiac death with stuff in the ECG, waveforms in the ECG. And that's already very valuable because right now it's really hard to study people who die because they're dead. And we would really like to be able to study them before that happens so that we can do all these investigations, learn more about it with a view to saving these hundreds of thousands of lives every year. But it's hard to know how to turn that correlation into a hypothesis because right now that knowledge is locked up in this model, this alien intelligence that knows that there's a correlation, but can't explain in our language what the correlation is. So the model knows how to read the ECG. Like, how do we get it to teach us? Well, how do humans teach? One way, especially for visual phenomena, is basically by like cartoons or caricature. And if you think about how you first learned about anything like what is a cat, like what is an ST elevation, you kind of hold a lot of things constant and change the one thing you want to focus attention on. And that's, I think, a useful insight. And I should point out this is different from what the standard interpretability tools do, because like you've probably seen heat maps of X-rays or ECGs. Those are useful for telling you where the model is looking, but not for telling you what it's looking at. Okay, so we do something different, which is we build a generative model of ECG waveforms. So you can think of this as like chat ECG. And it learns from the same data set of like ECGs. So you show it a bunch of ECGs, you ask it like, okay, with this data constraint, produce that same ECG. So it's a compression algorithm. So it learns the structure of what an ECG waveform looks like. And then we start with one of these fake ECGs that, you know, it's a real patient's ECG put through this model. And we ask the model, okay, generate a bunch of ECGs that look very much like that first ECG, but with subtle variations in the waveform that still look like ECGs. So there are lots of waveforms that don't look like ECGs, and that's the trick in building one of these models. Like most waveforms are not ECGs. So you need to teach the model what an ECG looks like first. But then you start with one, and you tell the model, okay, generate a bunch of ECGs like this one. And then we run our predictive model, and we find one that's higher risk. And then we do it again, and again, and again, and again. The first thing we do is verify that this works with something we know about. And so this is an ECG that morphs up and down on the feature called left bundle branch block, or QRS duration. You can see it's kind of like the model's like doing an okay job of adjusting that QRS interval as we tell it to go up or down. So it passes a first check. Here's when we ask it to do it for our sudden cardiac death predictor. And so I saw that we'd chosen a somewhat counterintuitive color scheme, but low risk is orange and high risk is purple. And what you can see is that, and so this is one person or like one fake ECG at a time. So these are 4 fake ECGs, 3 leads. And what you can see is that as the model goes from high risk or low risk, sorry, to high risk, everything gets kind of squished. Everything is just kind of lower amplitude towards that 0 voltage point that we've standardized to 0. And that's kind of interesting. And so that's the beginning of an answer to your question of like what that model is seeing. And I think that illustrates a very, very important point about how humans and AI fit together here. Because this model is seeing that correlation, and it can tell us what it's seeing, but the model can't reason about the mechanism, about what's going on in the heart. Because for a very simple reason, it's not that models can't reason or that you can't build reasoning into model. You can do whatever you want with the model, but the model has to learn from something. And in this data set, there's no cardiac electrophysiology. There's nothing about sodium channels or about myocytes, geometry, the conduction system. There's just SCD and ECG. That's it. And so maybe I'll pause and just ask you to do what the AI can't and think about what could this be? What shrinks amplitude like that? I don't know. I'm not qualified to ask or to answer this question, but I'd be really curious if anyone has ideas. Ziad and I talked about some earlier today.
Cardiomyopathy or pericardial effusion.
Mm-hmm. Yeah, so it could be something outside the heart that's blocking. So visceral fat, COPD, something like that. Yeah, great ideas. Like another thought that I had, which I think looking at the QRS interval maybe seems less likely, is fibrosis of some kind. But there are lots of things that our mind starts doing, tying the change we see in that waveform to our understanding of what's going on in the heart. And this is not something AI can do. And those mechanisms are really, really important for pushing forward the science, because they're the basis for getting more tests. Like, what kind of tests do we get on these people? For trying new treatments. And none of those things are in the data because we haven't done them yet. So there's no, like, the people who are getting cardiac MRIs are getting them for reasons that cardiologists know about today, not because cardiologists are worried about sudden cardiac death risk. And so these things are not in the data, and the AI cannot tell us what to do, but it can tell us enough to get us thinking about these mechanisms so that we can start reasoning through what to do next. Like, a good way to think about this is that an AI could never have discovered defibrillation. There's no electric shocks in the data set before defibrillators are discovered and put into use. So there are these hard limits on what AI can do based on what's in the data. But the good news is that we have a lot of things in our head that are not in the data. And that's a very valuable complementarity between AI and humans. A lot of people, I think before ChatGPT anyway, I think a lot of people thought, oh, human doctors are never going to be out of a job because no one wants to interact with an AI. They want to get bad news or good news from doctors, and doctors are so empathetic, and it's like, that is not what we should be counting on to keep us in the job. Empathy and ease of interaction. But this, on the other hand, is going to keep us in the job. It's the stuff that's not in the data that we know that the model doesn't. All right, let me summarize. 2 areas where AI is, I think, going to be transformative. One is medical decision-making, and specifically allocating scarce resources like defibrillators, but also like testing for acute coronary syndromes with catheterizations, or mammograms for breast cancer screening, or a lot of other things that, at least from projects that I've done over the past 5-6 years, I've become convinced that AI is going to have this huge effect in correcting human predictions that are suboptimal, to say the least, and allocating these very scarce, valuable resources away from the low-value people that we're currently giving them to, and towards high-value people that we're not currently giving them to. And I think that's going to both improve outcomes and reduce the cost of care. And it's very rare to have those 2 things go together. Normally, they are negatively correlated. I think medical discovery is the other area where there's going to be a huge transformation over the next few decades, because that discovery process is a very complicated loop that involves noticing and correlating and forming hypotheses and building a mental model of what's going on. And that's something that AI cannot do alone, and where AI and humans are going to work together. And my heuristic for seeing that is like, what's in the data? AI is going to do that very well. What's not? Humans are going to do that much better. And I think that's going to be the core of rebuilding that new and I think much better version of the science of medicine over the next few decades. Thanks.
Great, thank you. Let me start with a couple of questions. Sounds like there's a certain probability of sudden death that buys you another test, an MRI or an echo. Why? I mean, I can imagine a world where there's a certain probability of sudden death that would buy you a defibrillator. What is that number, and why? And do you think we're capable of achieving that without explainability, without, like, it's just finding something, we don't understand what its correlation is, but it correlates so well that you need the intervention?
Yeah, it's a great question, because I think so many medical decisions are these sequential, it's like this sequence of decision and if-then statements. The way I think about it, or at least I guess the way an economist would think about it, is there is a cost of the defibrillator, which is like, the risks and the actual financial costs. And then there's the benefit. And in this case, the benefit is proportional to your risk of sudden cardiac death that is treatable by a defibrillator. And if you're above that risk, you should get a defibrillator. And if you're below, you should not. And so if I see a new patient knowing nothing about them, my best guess as to their sudden cardiac death risk is just the population average. But then I do an ECG, and then I see this squiggle, and I'm like, oh, now it's much higher. And so basically, I can order as many tests as I want to get that patient above or below the threshold. But once they cross the threshold, they need it. That's the way, at least, I model the decision process. So the role of the test is producing information that updates your belief about their risk, and that lets you make that decision about the defibrillator.
But you don't think it gets you ever to the point where just that test itself is good enough without? Because I'm wondering, are we getting the MRI because we need to sort of understand mechanistically? We don't trust. Yeah. We don't trust your squiggles to guide us on something that's expensive and a little bit toxic? I
think this is a fascinating question. I think there are a lot of different opinions on this. And I think that there's one view that's like, oh yeah, doctors need to understand things. I don't know if you know, there are these studies, psychology literature, where they ask people things like, do you understand how a toilet works? And everyone's like, yeah, of course I understand how a toilet works. And then the experimenter is like, great, here's a pencil and a piece of paper. Draw me exactly how the toilet works. And approximately 0% of people. So I think understanding is a very fluid concept. Yeah. And in a lot of cases, our understanding is extremely superficial. And I think a great example of that is left ventricular ejection fraction. It's like, oh, okay, that's why they needed defibrillators, because their EF is 30. But is that why they like it? So why do they need it? Well, it's because we see a high risk of arrhythmia, and because we've done trials that show a benefit in that population, and that's how we understand it. So I think genuine understanding is a very high bar, and if that's our bar, I wouldn't be allowed to order an MRI, because I don't understand how the spin and the magnets work. It's just, there's some physics. Similar to a toilet, I think. Yeah, I get it, and I can look at the image, but do I understand it?
Got it. Yeah.
So great talk, Ziad, and I think it strikes me that you're trying to put us electrophysiologists out at work. I have many questions, but let me just focus on one. When you showed that QRS and what your algorithm picked up, it looked like it was QRS amplitude decline. What strikes me as an EP is what it didn't pick up, such as QRS widening. Yeah. So bundle branch blocks we know are increased risk, or QT prolongation, which I didn't see, or PDCs. So how do you explain some of the things that we know to be high risk that didn't get picked up?
Yeah, it's a great question. I think there's a lot of, so if you think about our procedure, starting from one ECG and then following a risk arrow in one direction, there's probably not just one direction. There's probably a bunch of different directions. Depending on where you start, you're actually going to get different waveforms. And so we need to do a much more comprehensive set of experiments to see if there are actually multiple arrows that we need to follow to map out that landscape. And I think it's a really nice idea for testing this, is like, can it actually get us to, can it reproduce the knowledge we already have about markers of risk? And I think it's a great thing that we'll definitely try, and I'd love to run it by you when we do.
And as you know, last week Ziad spoke about cardiac death, and so this is all sort of coming together, but in some ways complementary approaches of really remarkable epidemiology. Anything on? Do we have something over there? Yeah, David. No, you're good here.
So you mentioned that in your Swedish data set that the mean number of ECGs per patient was 3 or 4, I think. But I don't think you mentioned ECGs. So is the risk score stable and within patients, or does it change? And if it changes, does that mean something more than just any single analysis?
Yeah. And can I also add the confounding question, which is the person who gets an EKG, probably there was a reason that that person got an EKG, and is that, how do you adjust for that as you look for these correlations?
Yeah, I think there's one huge caveat to this whole enterprise, which is that it only works in people who have gotten an ECG. And I think that it's, now that's a much bigger number of people than have gotten an echo or any other test that we can use. So it's already good, but it's not perfect. Now, some of that goes away when you're looking at multiple ECGs within a person. And one thing we found is that it is actually pretty dynamic. And so, for example, one thing that checks out is that in people who have had an MI in the previous 30 or 40 days, it goes up. But there are also some changes as a function of medications that we're starting to map out. So when you start a beta blocker or a ACE inhibitor or something like that, what happens to your risk? There are some methodological challenges to answering that question, but I think that the dynamic risk question is both super interesting and also a huge advantage of having a cheap biomarker like an ECG that you can do over time. See, for example, even response to treatments.
Well, as we mentioned, the dynamic risk issue. How many people are wearing an Apple Watch here? All right, so these people are having their dynamic risk measured every nanosecond. Yeah. How's that going to be influencing your work?
Yeah, I think that is such a different population from the population of people who are getting a 12-week ECG in a facility, right? That I don't know how much it would translate. I think there's another problem that Apple and other people who are collecting these wearable data face, which is that those data live in a silo, and outside of like the Apple Health or like the heart study, those data can't be linked to any other data to figure out like, well, if I predict high or low, am I right? So I think that wearables introduce a whole like new set of great opportunities to cut the health system out of the loop, which is great, unless you're the health system. But it also
there is that. Yes.
It also introduces a lot of challenges related to the sampling, the quality of the data, and the fact that people, at least for now, people are not getting the ECG measured continuously. They have to decide to do the ECG. That's not random.
Yeah. Do you want? We'll take one last one from online.
Combining some of the 200 people watching online, their questions. Basically, a lot of people wondering about the validation problem, like you talked about, but then taking that one step further, health system, it's very costly for health systems to do the hard work of validation. And so do you end up with a bunch of shadow algorithms or healthcare systems that are not embedded into the EHR that ultimately drives costs for healthcare for everyone?
Yeah, the integration question, I think is really important. It's one that is currently, I think there are a lot of people working on it. I think it's, given what we all know about the state of the electronic medical record, it's a really hard problem because it's just this thicket of different software, and the ECGs actually live in a totally different place from the EMR. The ability to intervene on physician behavior via the EMR is very limited in the leading vendor of electronic medical records. And so I think it's as yet an unsolved problem. I think the good news is that we know that it needs to happen, and it is just a technical problem. It's a lot of brute force and plumbing, but it is just a technical problem. So I think as we start to see algorithms that actually create value, which I think we haven't seen that many so far, in part because of the difficulties of getting data and building algorithms. But as there starts to be use cases that health systems and insurance companies pay attention to, I'm pretty confident that problem will get solved.
Ziad, we got to quit. Thank you. That was fantastic, and I really appreciate you being here.